Hello to everyone. My name is Maria Victoria Mateos. I work as a hematologist at the University Hospital of Salamanca in Spain, and we are here attending EHA 2024 in Madrid, and I will present on behalf of all co-investigators of the DREAMM-7 clinical study the results of a phase 3 randomized clinical study conducted in relapsed refractory myeloma patients after at least one prior line of therapy, in which Belantamab in combination with bortezomib and dexamethasone has been compared with Daratumumab in combination with bortezomib and dexamethasone. As you know, Belantamab is the first BCMA antibody drug conjugated with monomethyl auristatin F. And in this study, 494 patients were included. All patients had received at least one prior line of therapy. The median number of prior lines was 1, and of note, 52% of the patients were exposed to lenalidomide, and approximately 1/3 of them were indeed refractory to lenalidomide. The primary endpoint of this study was progression-free survival, and the trial met its primary endpoint. BelaVd resulted into a significantly and clinically meaningful longer progression-free survival in comparison with DaraVd. The median PFS was 36.6 months versus 13.4 months, with a hazard ratio of 0.41. And what is also important is to remark that the superiority for BelaVd was sustained across the different subgroup of patients, including challenging populations, those patients refractory to lenalidomide, or those patients with high-risk cytogenetic abnormalities. The superiority for BelaVd was also observed in terms of overall response rate, complete response rate or better, and it was basically the double, 34% for BelaVd versus 17% for DaraVd. But also we know that in myeloma, minimal residual disease negativity is maybe the most powerful prognostic marker. And BelaVd resulted also in approximately 25% of MRD negativity rate, clearly superior to no more than 9% observed with DaraVd. Although the follow-up is not very long at the present time, approximately 28 months, we see already a clear trend to benefit in terms of overall survival, but it is also relevant with a hazard ratio of 0.57. Durability of the response is also longer for BelaVd. And in terms of safety profile, BelaVd resulted numerically in higher incidence of adverse events. From the hematological point of view, thrombocytopenia is the most frequent one, and from the non-hematological point of view, we have to concentrate on the ocular events. And when we evaluated the best corrected visual acuity, it's true that approximately 34% of the patients experienced a worsening in the visual acuity from normal visual acuity with blurred vision, but only 5 patients reported an impaired vision with a best corrected visual acuity of 2200. And in addition, and I think that this is very important indeed for patients, with those delays and those modifications, all patients basically resolved the keratopathy. And what we've seen in the DREAMM-7 is at the beginning, Belantamab was delivered every 3 weeks, but over treatment, the majority of the patients had to increase the time between 2 administrations until 10 or 12 weeks. This fact didn't impact in the efficacy, but resulted in a significantly lower incidence of ocular events and into a significant reduction of the number of patients who had to discontinue Belantamab. So overall, I think that all these data clearly support the role of Belantamab, bortezomib, and dexamethasone as a new potential combination for relapsed refractory myeloma patients after one prior line of therapy. And with this new combination, we are going definitely to increase the number of possibilities for our myeloma patients after just one prior line of therapy. And we know how the BCMA targeted therapy are rapidly moving to the first line of therapy. Filtafel is already approved. Bispecific monoclonal antibodies are coming, and we are going to have now also Belantamab in combination with VD, maybe based on the DREAMM-7 also Belantamab in combination with PD. And from my personal point of view, I think that this will allow us to deliver a much more personalized therapy for each patient based on their characteristics, based on this lifestyle and based on the risk status as well as comorbidities. Thank you very much.